Dr. Dupree, Beth, you're a breast surgeon and you're in charge of a whole service line, and there's a COVID-19 Breast Cancer Consortium set of recommendations, I understand, that allows us to triage and figure out who needs to go forward with their treatment right away and who can safely wait 10 to 12 weeks to take the next step in their care. Can you tell us a little bit more about that?
So the recommendations by the COVID-19 Pandemic Breast Cancer Consortium we're using them. We used them this morning in our tumor board to get medical oncology, surgical oncology, and radiation oncology all on the same page so that the patients get a consistent, clear message that we are all we are all part of their team, and we're all speaking the same language and messaging their care the exact same way.
That's so helpful to know. Some of the patients that you take care of will be, let's say, have very early stage of disease or a very favorable type of breast cancer. Those are the type of patients, for example, that we can safely wait those 10 to 12 weeks until surgery can be scheduled. And for those patients who are waiting, they can initiate anti-estrogen therapy in most cases in order to feel like and to truly be under care, starting their treatment even though their surgery has been delayed. That's part of the recommendations. Can you just say more about that, the basis of that?
So neoadjuvant anti-estrogen therapy has been widely used, particularly in European studies, where there may be a delay for whatever reason, whether there's access to ORs or whatever. But we know that tumors that are low biologically active tumors, meaning low grade, or what we call, they would be luminal A tumors, tumors that have a very good prognosis, can safely be given anti-estrogen therapy. I've used it for years to shrink tumors to be able to do more breast conserving surgery. Sometimes patients have a larger tumor, and if we give what we call neoadjuvant or anti-estrogen therapy prior to surgery, we can sometimes downstage or shrink those tumors to be able to get better cosmesis. So this is not something that's new and that we're experimenting on with patients with COVID. This is well-documented standard of care for a lot of these patients. So what we're doing is extending that, basically saying, we're going to just, across the board, these patients that we can say will not benefit from chemo most likely can go on the anti-estrogen medicine and wait until after the dust settles, so to speak.
Absolutely. And when you say you've been doing it for years, it's been part of your practice, but for patients who get on it, they're not on it for years before their surgery. They're on it for a short period of time, just until the surgery can get back on your schedule. Then they have their surgery, then they will, just like they would under normal circumstances, start the anti-estrogen therapy at the appropriate time after surgery has been done.
Correct. And most patients will either do 3 to 6 months if they're doing neoadjuvant anti-estrogen therapy. And we do follow them. We track them to make sure that the tumor's not getting bigger and that it's actually shrinking. And that's one of the recommendations, is that we see these patients about 6 to 8 weeks after we start the anti-estrogen therapy, so that we can do an ultrasound or an evaluation, so that we can, again, it's to make sure that the patients know that they're getting the appropriate treatment, and to let us know if this tumor is behaving differently than we believed.
That's really smart. Thank you so much. That's so helpful to so many people who are really out there worrying about this right now.